Shall we start? Hello, Assalamu alaikum wa rahmatullah. Hello, everyone. I'd like to welcome you today to the Dyslipidemia Masterclass webinar Wave 2. The webinar has been organized by the Emirates Diabetes and Endocrine Society, and it's being sponsored by Amgen Pharmaceuticals. Today, our webinar is basically focusing on the guideline-directed therapy and the therapeutic sequences. We're going to have four esteemed speakers who are going to discuss the dyslipidemia management in details, and I assure you, you're going to enjoy this webinar. So today, I'll be your host, and I'm Dr. Aladdin Bashir. I'm a consultant endocrinologist at Dubai Hospital. And I'm going to present the speakers and moderate the session, inshallah. So today, just a reminder that this session is being live streamed in the EDS YouTube channel. The webinar is CME accredited, and I urge you to type any questions in the Q&A box, and I'd like you to mention the name of the speaker so we can direct the question to that specific speaker. The webinar as well is available as on-demand webinar, and it will be available on demand on the EDS Institute website. So the agenda today is going to focus on a couple of areas in management of dyslipidemia, and we're going to start with cardiovascular risk stratification from bench to lab, and we're going to focus on cardiometabolic guidelines, UAE cardiometabolic guidelines, and then we're going to discuss harmonizing the global LDL targets and the role of statin optimization. We're going to focus on hypertriglyceridemia and its risk on cardiovascular disease and how and when to intervene. And we're going then to have a clinical scenarios based on the guidelines, and then we'll have at the end an industry symposium. Each presentation is going to be around 20 minutes, and we're going to have a break for Maghrib prayer, like in Dubai timings. We'll have around 7 minutes for Maghrib prayer. So our first speaker is Professor Mohammed Hassanin. Professor Hassanin is well known to all of you. He is a friend and a brother. He is a professor at the MBRU University. He's a consultant endocrinologist, senior consultant endocrinologist, and he is the chair of the Diabetes and Ramadan International Alliance. He is a co-founder of Cardiff University Diabetes Diploma and Master since 2007, and he has published a significant number of publications related to Ramadan and outside the area of Ramadan. He is one of the mentors in our institute, and many of the physicians, whether junior or senior, has learned significantly from him. I'd like to welcome Dr. Hassanin. One important point is he is one of the principal authors of the UAE guidelines for cardiometabolic and type 2 diabetes. And hence, he is going to discuss the risk stratification based on these guidelines. Welcome, Dr. Hassan, and you can share your screen.
Thank you, Ala, for the very kind introduction. Always pleasure to be with EDS and with you and all the colleagues. So let me share my presentation. And been asked to look into the cardiovascular risk stratification based on the cardiometabolic guidelines. And it's a delighted opportunity to share with you all of this information. I mean, I don't need to tell the audience very much that every 6 seconds there's a person who dies with diabetes-related complications, whether they are cardiac or cerebral, and many have other complications, don't necessarily die, but retinopathy, nephropathy, and foot amputations are very serious complications that people with diabetes dread to have. Now, guidelines have evolved, and 10 years ago or so, it became very clear to us that not only we need to think of the classic cardiovascular risk factors, but of course, we need to think of these 4 pillars: good glycemic control, good weight management, and also, very importantly, over the last 10 years, the specific drugs that have the ability to lower the cardiorenal outcome regardless of their impact on glycemic control. I personally like and love this quote by Hippocrates, where it's very important to understand the person and not just focus on the disease. And in doing so, I would like to think and reflect on us living in the Gulf region, living in UAE, and the Middle East in general. What do we do for the weekend? We get together, we go to a nice restaurant or eat together at home. We go maybe to the shopping in the mall, and we do very little physical activity. Even if the car park is a bit far, there will be valet parking. And many, unfortunately, smoking shisha specifically has become like a social event rather than a serious health issue. Physical activity is pretty down. When I reflect on the data that we had from the MENA trial, looking into people from Middle East and North Africa, and normally when you ask people about their physical activity, they exaggerate it. So you can see here, inactivity or low level of physical activity was quoted by nearly 2/3 of the population of this large study of 1,800 persons or so. So we, as I shown you from the previous slides, our physical activity is very down. When I look again into data about our weight, and this is data from Dubai Household Survey, and we have plenty of other data that have proven more or less the same. I've marked in orange, the box in orange, the young people between the age of 18 and 30. These are the people at their prime sort of physical activity, maybe much more active than others. But when you see 50% are overweight in their 30s and nearly 25% in their 20s and 18. Obesity among them is 10 and 19%. Obviously, I expect that when people get older to be heavier in weight, but it does look like the cutoff age is the 30s. Then, because as you can see here, there's hardly any difference in the level of overweight or obesity once people hit the 40s. So it's very interesting what happened to the physical activity of people and what they eat. When we reflect on the data again, based on gender, it does look like women are more obese and men are more overweight. Now, I understand that women, as they get older, maybe because of pregnancies and so forth, but it's hard to describe it in men. Now, part of this, what happened to our diet? I'm from Egypt. Mediterranean diet is with plenty of fruits and vegetables. And the fruit here in UAE is available all year round. Supermarkets are packed with all the excellent goods. But as you can see here, regardless of the nationality, only 36% are having the required sufficient fruits and vegetables. And specifically, when they've been asked about consuming the 5 portions of daily fruits or vegetables, this is done by the minority. The vast majority are doing it 1 or 3 days per week. So our eating habits has changed. When we asked them in Dubai, what do you do? The amount of people doing moderate physical activity, which basically was 10 minutes only of activity during routine work or household. So let's say in our hospital, 10 minutes of walking from one department to another, or 10 minutes of playing football or something similar. This is done by 5% of the population and the moderate by 17%. So the vast majority of us, I've shown you, are not eating the right food and they are not doing the physical activity. So consequently, this reflects on obesity. When you look into the level of obesity in people with normal weight, it's 8%. But unfortunately, when you look into in those who are obese, it's 21%, which is exactly the same pattern in people who are exercising versus not exercising based on the Dubai household survey. Now, another very important factor, the age of people developing diabetes. This is a study that we've done in Alexandria, my home city, and you can see here, people under the age of 20 or in their 30s, the amount of people with diabetes is 15% in their 30s. It's massive amount of diabetes, even in countries, a country such as Egypt, where necessarily the wealth is not similar to the Gulf wealth and the temperature is not similar to the hot weather, where it's always people say it's too hot for me to exercise. So unfortunately, we have this. Now, when you go to other risk factors in Dubai, here is the Dubai Household Survey looking into blood pressure. And here we classified people arbitrarily into normal blood pressure below 120/80, pre-hypertension between 120 to 140, or diastolic of 80 to 90, or above 140/90, which was considered as hypertension. You might argue with the figures. Obviously, if you lower the figures, it would become even worse. So it's a third, a third, a third, a third. A third with normal blood pressure, a third with pre-hypertension, and a third with frank figures that indicate hypertension. Smoking. Smoking has currently increased massively. 21%, 1 in 5 of males are considered as current smokers. So, and in women, which naturally in our region is not very socially acceptable, so many deny that they are smokers. Nevertheless, it is 8%. So 1 in 5 or over 1 in 5 males are a smoker. So when you reflect on all of these figures from obesity, physical activity, what type of food we eat, level of hypertension and level of smoking, it makes you wonder that we really need to address all of this with guidelines. This is the ADA standards of care of last year, and as you can see, it focuses on the 4 pillars that we've addressed before: lipids management, blood pressure management, specific agents for cardiovascular and kidney benefit, as well as glycemic management. Our topic for tonight is lipids, and I will try to address all of them. It's very excellent work that we have done jointly between the Cardiac and the Endocrine Society of United Arab Emirates. Massive number of eminent authors got together to produce this very good level of guidelines. We need the guidelines because primary care deal with 90% of people with diabetes, and they have very little time to address all the cardiovascular risks as well as glycemic control and all other problems. The average consultation is about 15 minutes, 10 to 15 minutes. So they really need something pretty simple to avoid the complexity of all of these issues. And of course, we need to think of the person with diabetes in the center of the circle. And all of us, cardiologists, endocrinologists, nephrologists, ophthalmologists, primary care, everyone trying to help as much as possible to minimize the risk. Of course, changing the lifestyle, which I've highlighted earlier. how the smoking levels, the type of food we eat, the physical activity, certainly the sleep and the stress are very important factors to try to help. But we obviously know that over the last 10 years, specifically since 2016, with the EMPEREC trial of empagliflozin, we recognize that there are certain drugs beyond their glycemic effect. They are able to help the cardiac and the renal outcome of people with diabetes. And the same applies to many of the GLP-1 receptor agonists or the GLP-GIP. Obviously, we had the classic evidence regarding the lipid lowering, as well as the antihypertensive and the antiplatelets, but these were the addition to our evidence-based medicine of what we should do. So the guidelines aim is to address all of these factors together in a simple manner. And consequently, we said we have to screen every single person with prediabetes or with type 2 diabetes or with type 1 diabetes over 10 years duration, or if they are adults with diabetes. And here we've included the prediabetes in recognition that many people with prediabetes have very similar cardiometabolic problems, and indeed many of the cardiovascular outcome trials that were done in people who do not have diabetes, their HbA1c was in the prediabetes range. So it's very important to think of glycemia as a continuum rather than just wait for the exact figure. There is no difference in my mind of a person's HbA1c of 6.4 and 6.5. One of them is officially prediabetes and the other is diabetes. So how should we screen? ABC is to look into thorough symptoms of cardiovascular disease, because a person with diabetes is not necessarily going to come and say, I have crushing chest pain. Many of them are subtle symptoms, especially if they are not exercising. It's called angina on effort, shortness of breath on effort, claudication at certain level of physical activity. But if I'm doing none of this, then it becomes very difficult to assess by symptoms unless you probe the person with detailed symptoms that might be subtle. And of course, then a thorough examination. And of course, this is what many people do, but we propose once a year to check the peripheral pulse regardless of age, including the ABI and the retinal examination. And one would say, but this is not done or recommended as routine for every person in Europe, in European guidelines or American guidelines. Yes, because the lifestyle is different. Physical activity there is far much more frequently done, so people are likely to be symptomatic rather than in our community. Then it comes to the investigations. What should we order? Of course, we should order the HbA1c, the full blood picture, the lipid profile, the renal function, including ACR, but don't forget an annual ECG as well as a proBNP with the knowledge of the high risk of the population that we have, including having diabetes at very young age and living with diabetes by the age of mid-40s. They probably had diabetes well over 10 years and sometimes over 20 years. A reminder again of the symptoms and signs of cardiovascular disease or macrovascular disease that are not necessarily straightforward. Fatigue, effort intolerance, dizziness. These are not the classic symptoms, but they are good hint that maybe this is of a cardiac origin. And of course, the measurement of the ankle brachial index is a very simple bedside test, which is basically the blood pressure around the ankle divided by the blood pressure of the arm, and you get the equation, and from the equation you will be able to decide whether this is normal or abnormal. So if we do this on an annual basis, perhaps in a person with prediabetes who turns out to be very low risk, then maybe we can relax it to every 2 to 3 years. And of course, if the person proves to have any of these abnormalities, then it should initiate a referral. So a person with abnormal physical examination or abnormal pulse or ABI or retinal examination or a person with abnormal ECG, abnormal proBNP, or abnormal renal function would be considered as a screen positive, and that person should be referred, early referral to the specialist. Which specialist? According to the type of the problem. If it's retinopathy, then certainly an ophthalmologist and so on. But then we have to address the lifestyle in a more prominent way. The smoking cessation, the weight management, the physical activity, the type of food. And then we must consider all of these people in the very high risk category. And I will come to what does that mean. But the question would be, what about those who would be screened as negative? Then we apply for them the United Arab Emirates cardiometabolic risk score. In our risk score, we've included age of 40 as a risk factor, duration of diabetes of 10 years as a risk factor, as well as the number of the classic cardiovascular risks, which is hypertension, smoking, dyslipidemia, and obesity, as classic risk factors. And you would quantify the risk of the person. So if I have a person who is 40 plus with a duration of diabetes of over 10 years and they have multiple risk factors, that will score 2 plus 1 plus 1. That person would score 4 and will take that person into very high risk category automatically. So this is pretty simple and pretty straightforward, and it really should be implemented in most of our centers. So what do we do? Well, we need to think of the level of the risk quantification. So that person would need an SGLT2 inhibitor or a GLP-1 receptor agonist of evidence, regardless of their glycemic control. And if the glycemic control is above target, after adding 1, then we combine the two together. The blood pressure target should be below 130 over 80 using a RAS blockade, and the LDL target here should be less than 55 milligram per DL using a high intensity statin, and antiplatelets would be indicated, obviously taking into account the history and the other disease condition of the person. A person who scores high or 3, then that person not necessarily to write them SGLT2 or GLP-1 straight away, but you can opt to select one of these instead of one of the other medication according to your preference. But certainly, if the person glycemic control is above target, and mind you here, we did not specify the targets. So the target varies from a person to person, and maybe then it's an opportunity to introduce these drugs earlier. The LDL target here is below 7, and you might consider antiplatelets. Do we have people with moderate or low risk? Yes, of course, because of the very young age that sometimes we diagnose people with who are not necessarily with all the cardiovascular risk factors, and here you would treat them with any glycemic agent to achieve target, aim for a blood pressure below 130, and try to use any antihypertensive agent, and the LDL target here is either below 100 or below 120. Of course, these are dynamic situations, and these guidelines were published 3 years ago, and they are due for update. So perhaps with the most latest guidelines, we'll be looking into these figures within the next few months when we prepare for the update of the cardiometabolic target. Well, it doesn't stop here. Of course, we need to think of the other important points. We need to think of that people with cardiovascular disease and end organ damage, or those who are screen positive, should be treated as a very high risk group, and this is really quite important. Here, we need to address every single parameter, including the smoking cessation, the weight management, and the physical activity. We should not forget the types of drugs which are dynamic, with many are added to the list of drugs that have cardiovascular outcome benefit, and the preference of when I would choose an SGLT2 versus a GLP-1. When it comes to lipids, and our masterclass tonight is related to lipids, don't forget that the first target is LDL, but we do not stop at statins. If the target is not achieved, then we need to add other lipid-lowering agents with evidence of benefit. And the list here is long, and I'm sure during the course of tonight, we will be addressing this. And also, we should be thinking of other lipid targets once the LDL target is achieved as per the guidelines. So, to me, the situation is clear. We need to try to achieve targets. And obviously, we are in the middle of the World Cup, and getting to the target is quite important. Why? Because the data from the Swedish register has proven to us that if we can address the main risk factors, the 5 risk factors, regardless of the age, the person with diabetes will not have an increased cardiovascular risk compared to the non-diabetic. However, if we don't, regardless of the age as well, then the hazard ratio will be high. And then people will lose 5.7 years of their life. So it's really important that we try to get to targets and think holistically rather than just focus on one aspect and ignore the other aspects. So with this, I would like to remind you about the 4 pillars: the drugs with cardiovascular outcome and renal outcome, lipids management, blood pressure management, glycemic management, lifestyle modification, including the smoking and the weight and the physical activity, so that the person with diabetes can prevent and survive any of these complications. Thank you. I'll leave you with the pictures from my beloved city, Alexandria. Thank you very much.
Thank you very much, Dr. Hassanin. Quite comprehensive review of the UAE guidelines. And now we'll proceed to the second speaker. Our second speaker is Professor Mark Sepatin. Professor Mark is the chairman of the TIMI study group, the thrombolysis in myocardial infarction group at Brigham and Women's Hospital. He has been endowed the Louis Dexter Chair in Cardiovascular Medicine. He's a professor of medicine at Harvard Medical School, and he has been internationally recognized as an expert in cardiovascular medicine and cardiometabolic risk. He leads a large scale of global clinical trials shaping cardiovascular and therapeutics. He's an author of more than 200 peer-reviewed publications in leading medical journals, and he's the deputy editor of JAMA Cardiology. He's also a member of the International Guideline Writing Committee groups in cardiovascular medicine. Professor Sepatin is going to talk to us about the harmonizing the global LDL targets and statin optimization. Professor Sepatin, you're welcome. The floor is yours.
Great. Well, thanks so much for having me. I've done one of these master classes in the past, and I really enjoyed it very much. So real privilege to be here. Let me start to share my slides. And okay, so hopefully that looks good for everyone. And so I really enjoyed the talk that was just given, and hopefully I'll give some data that will be, if you will, food for thought about what the targets might be for LDL cholesterol based on all the recent data that we have in hand. Here are my disclosures. Okay, so let me start with the data for PCSK9 inhibitors, and these are data now that are about 9 years old now, when we presented the results for the first trial to look at adding a PCSK9 inhibitor to statin therapy. That was the Fourier trial. Large trial with over 27,000 patients, very high risk. They had prior MI, stroke, or PAD on optimized statin therapy. Although relatively brief follow-up period of only 2.2 years, we had wanted it to be longer, but a variety of forces sort of conspired for the trial to be shorter. And a 20% reduction in CV death, MI, or stroke. But I'll draw your attention to the figure on the left. That shows the LDL cholesterol levels during the trial. And you can see in the evolocumab arm, we got levels down to about 30 milligrams per deciliter, about 3/4 of a millimole per liter. I think the lowest of any major cardiovascular outcomes trial. So that's what we achieved in the trial. After that, the US guidelines came out, and I'll say had a sort of modest incorporation of the data. And so they noted that if the LDL cholesterol was greater than or equal to 70 milligrams per deciliter, start with ezetimibe. We had shown in the Improve-It trial years earlier that there was a benefit for adding ezetimibe, for sure, cardiovascular benefit. But the LDL reduction with ezetimibe is rather modest, on the order of 24% or so. And if it still remained high, then you could consider adding a PCSK9 inhibitor. That actually wasn't how Fourier was designed. They note on the right-hand side that actually the way the trial was designed is you could just go on top of statin therapy to add a PCSK9 inhibitor. But at that time, the PCSK9 inhibitors were very expensive. And so these guidelines were really written through the lens of an intense focus on cost effectiveness. They also made this distinction for clinical ASCVD. They subset it, as you can see at the top, into those at very high risk and those not at very high risk. And what does that mean? Basically, they took the inclusion criteria for Fourier and created this category of very high risk ASCVD. I'll get back to that point in a minute. Now, despite their recommendation, these were data from Fourier. This is one of my favorite subgroups. These were the individuals who came in with an LDL cholesterol under 70 milligrams per deciliter. So this is a level where, at that time, the US guidelines would have said, you're done. You don't need to do anything else. You can see there are LDLs. The median was 66 milligrams per deciliter. And we, with evolocumab, dropped the LDL down to 21 milligrams per deciliter. Super low level. If you look at the interquartile range, about a quarter of the patients were walking around with an LDL cholesterol level in the single digits, or maybe 10, 11, 12 milligrams per deciliter. Super low. But would this make a difference? Maybe they were already low enough. But the answer is it did make a difference. And so here are two forest plots. The upper one is the primary endpoint. The lower one is the key secondary endpoint. The black diamonds are the overall effect seen in the trial. And the filled green squares show the effect in the subgroup of patients who came in with an LDL under 70 milligrams per deciliter, and you can see they benefit just as much, right? 30% reduction in CV death, MI, or stroke. So should we be satisfied with an LDL of 70 milligrams per deciliter? Absolutely not for these individuals. We need to lower it further. So then the European guidelines then came out, and I think appropriately took a more intensive view. And in these very high-risk patients, which here really wasn't that category for that the American guidelines had with like multiple events, et cetera. This was just, you had ASCVD. But now they had a target of under 55 milligrams per deciliter. I will share with you that there were robust discussions during our guideline meeting about what the target should be. And there was, I would say, little debate that 40 milligrams per deciliter, which was roughly what we had achieved in the evolocumab arm in Fourier, was a great target. But it would be hard for people to get to that. And so we decided, at least in this guideline, to sort of start with 55. But we did work in language, and I've shown this at the bottom here, to consider for patients at very high risk. So those with a second vascular event, those while taking maximally tolerated statin therapy, to consider a target of under 40 milligrams per deciliter, which is actually personally what I target for all these patients. we recently did a very focused update for the guidelines, and we didn't address these targets in detail, but what we did do was modify the diagram to pull out what had just been buried in text, that consideration of targeting under 40 milligrams per deciliter. We needed to come up with a new adjective. We had done low, moderate, high, very high. We came up with extreme risk, and we codified it a bit more. Recurrent events, polyvascular disease. Okay, so, but now obviously the major new data was what we had presented for Vesalius-CV. We presented this back at the American Heart last year. This was another large trial, over 12,000 patients, but lower risk than Fourier. We moved down the risk pyramid. So now these patients had atherosclerosis or diabetes, but no prior MI, no prior stroke. Right? The notion is we had helped prevent patients from having another MI or having another stroke, but we'd like to prevent that first event. Again, they were on optimized lipid-lowering therapy, randomized to evolocumab or matching placebo. And here we stipulated that the median follow-up needed to be at least 4.5 years. We know from lipid-lowering trials that the benefit grows with time. What did the LDL cholesterol look like? This was looked at in a sub-study in the trial of about 2,000 individuals. And you can see in the evolocumab arm, again, we're achieving levels roughly a millimole per liter here, 45 milligrams per deciliter. And then the results, so a large 25% relative risk reduction for CHD death, MI, or ischemic stroke. You can see the curves sort of start to diverge a little bit in the first year and then really kind of take off thereafter. And then what we were able to do with this large LDL cholesterol reduction, as well as the long follow-up, was now show a nominal reduction in CV death, a hazard ratio of 0.79, nominal P of 0.032. The curves diverge after about 1.5 years. It's exactly when they diverged in the 4S trial and in the lipid trial. It takes time for lipid-lowering therapy to have its full benefit, right? We lower someone's LDL cholesterol, or we start them on a statin or a PCSK9 inhibitor or ezetimibe today. Their LDL cholesterol will reach a new steady state in 1 to 2 weeks. That will translate into healthier arteries, plaque stabilization, plaque regression, depending on the LDL cholesterol achieved. That happens over months. It's those healthier arteries that then translate into a lower risk of MI, lower risk of stroke. That happens over months to years. And it's that lower rate of MI and stroke that then translates into a lower rate of cardiovascular death. And then sort of the ultimate outcome, all-cause death, again, a nominal reduction here, hazard ratio 0.80, p-value 0.0005. So big benefit here. Now, some of you may be familiar with this data from the Cholesterol Treatment Trialist Collaboration Meta-Regression. These were data that came out in 2005 and updated in 2010. So this meta-regression is each square on this plot is a statin trial. Where it is on the x-axis depends on what the LDL difference was between the two arms in the trial. And where that dot is on the y-axis is whatever the risk reduction was in the trial. And it's from these analyses that we get the notion that for each millimole per liter, we lower LDL cholesterol, there's roughly a 20-ish% reduction in major coronary events or major vascular events. Well, how did Vesalius stack up for that? So as you can see, it's aligned extremely, extremely well for that. And that's important because that then indicates that if we see the same magnitude of benefit here per unit reduction in LDL cholesterol, and we got down to levels of around a millimole per liter, that means we should be targeting that for our patients, that there's benefit for lowering all the way down to those levels. Now, let me share with you some other data that's come out recently here. So this is the PCI subgroup. This was presented by Brian Bergmark from our group at EuroPCR this past May and published simultaneously in Circulation. This is the subset of individuals who've had a prior PCI. Now, again, they haven't had an MI. So this is sort of an elective PCI for atherosclerosis. And what you can see is a 30% reduction in CHD death, MI, or ischemic stroke, right? A 50% reduction in MI. So I think for our interventional colleagues, in addition to stenting a particular segment in the coronary tree that has a tight stenosis, need to think about the health, the entire health of the coronary tree, and think about the modifiable risk factors, importantly here for LDL reduction. And you can see this benefit here in these patients actually starts early, within 6 months. All right, you already have a significant reduction in the risk of MI. What about other patients? So Larry Leiter in our group presented these data at the American Diabetes Association meeting earlier this month in June for patients who had high-risk diabetes, 29% reduction in the risk of CHD death, MI, or stroke, right? 21% lower rate of all-cause mortality in these patients. So getting back to the patients with diabetes, even if they haven't had an MI or a stroke, right, that they still benefit from this reduction. For us, high-risk diabetes meant that they had either long-standing diabetes, at least a decade, they had evidence of microvascular disease, or they were on insulin therapy, right? And then you could get into Vesalius, 21% reduction, all-cause death. And then we also presented data on the subgroup who had no known significant atherosclerosis. This was about a third of the trial. What do I mean by that? They had no prior arterial revas. They had no known stenosis of 50% or more. They didn't have a known CAC of 100 or more. All right. How did these individuals do? 31% reduction in 3-point MACE, right? And if you look at mortality, right, nominal reductions in cardiovascular death and all-cause mortality for patients without significant known atherosclerosis. Now, in the remaining 5 or 6 minutes, I want to talk about sort of targets. And the last bit of data I want to share with you before we get into guidelines and targets are these data. This is from the Glagoff trial. This was an imaging trial using intravascular ultrasound, imaging plaque in coronary arteries at baseline and then 18 months later. And so patients were on statin therapy and they were randomized to get evolocumab or not, and evolocumab caused plaque regression. But even more interesting, I think, is this figure from the paper where they looked at the change in coronary atheroma volume as a function of the patient's on study, their on treatment LDL cholesterol. And what you can see is that if someone's LDL cholesterol was roughly 70, 80 milligrams per deciliter, on average, plaque stayed about the same. It grew a little bit in some people, it shrank a little bit in other people. On average, it was the same. If the cholesterol was greater than that, the plaque is growing. Plaque is growing if your LDL cholesterol is north of 70, 80 milligrams per deciliter. If it's less than that, plaque starts shrinking. And the lower it is, the more the plaque shrinks. And so from this, I think for primary prevention, if you want to take LDL cholesterol out of the equation as a risk factor for your patients for primary prevention, you should keep their LDL cholesterols under 70 milligrams per deciliter. And here's some other population data to support this notion. So to borrow from Dickens, this is a tale of 2 studies. On the left is MESA, which is a study in the US, 6 different communities, LDL cholesterol on average about 120 milligrams per deciliter, which is still what it is on average nowadays. On the right, the Chimani Health and Life History Project, a pre-industrial society in the Bolivian Amazon. Historically, their LDL cholesterol levels around 75 milligrams per deciliter. They did coronary artery calcium in both MESA and in the Amazon population. In MESA, the older individuals you saw the CAC scores moving up and up and up and up, right? So the atherosclerosis just inevitably developed in these individuals. What about in the Chimani, whose LDLs lifelong were only about 75 milligrams per deciliter? Nothing. they don't have any evidence of atherosclerosis. So that to me argues what we should do for primary prevention is try to be like the Chimani. So the US guidelines came out recently, but unfortunately, the nature of guidelines is it takes a long time to generate these documents. And so their literature search was only through December 2024. So they did not include data from Vesalius. What do they recommend? And I think that overall, the guideline is a great document, but I'm going to point out with the new data how we might refine this a bit further. They continue to divide patients with ASCVD into those at very high risk. So you need to have at least 2 events or 1 event and 2 high-risk conditions. That to me doesn't make a lot of sense. These were Fourier and Odyssey outcomes inclusion criteria for risk enhancers. They're not risk modifiers. They don't alter the efficacy of the drug. And so I don't think it makes sense to create this artificial category, nor does the FDA recognize that as a logical thing to do. But what do they recommend? If you're at very high risk, then they say, okay, get the LDL under 55 milligrams per deciliter. And if it's higher than that, then you should add ezetimibe or PCSK9 inhibitor. If you're not at very high risk, you should target being under 70. I don't think that's low enough. I think based on the data I showed you in Fourier and in Vesalius CV, we got these individuals down to about 40 milligrams per deciliter, and the benefit was proportional to that amount of lowering. And so that's what we should target for these individuals. Next, they did include a very nice part that now deals with subclinical atherosclerosis. We see this all the time now based on CAC scores or CT angiograms that individuals have, or just even non-CT angiograms seeing calcium there. Ton of cross-sectional imaging happening. That gives us valuable insight into athero that individuals might have. What do they recommend based on the amount of athero? Under 100, under 70, under 100, all depends. But these people have athero, all right? And so it's no different than Vesalius. What did we get people down to in Vesalius? We got them down to 40 milligrams per deciliter, and the benefit was proportional to that. If you have known atherosclerosis, even if just through imaging, I think you should get their LDL cholesterol down to under 40 milligrams per deciliter. We heard a lot about diabetes. What do the US guidelines recommend for that? Sort of oddly, this bizarre sort of start with moderate intensity stent. We know patients with diabetes are at high risk, so I'm not sure why you'd start with a moderate intensity stent. Makes no sense to me. And then this sort of ageism that if you're greater than 75, maybe consider a moderate intensity stent. People can still have many, many productive years after 75, so that makes no sense. In high-risk patients with diabetes, they say, okay, consider under 70. But that to me, again, we've seen in Vesalius, we got those people down to under 40. So I think if you're diabetes with no high risk, okay, maybe under 70, but any high risk features, you should be under 40 based on Vesalius. And then they have patients who don't have any of that. So they don't have known athero, they don't have diabetes. Then you use the prevent risk score and you bin them into these different risks. And there's one where they really, unless the LDL is sort of super high, they say if your risk is under 3%, you don't really need to consider lowering that any further. Even if your LDL is like 159, that's okay. That I think makes no sense. Now, where did this 3% recommendation come from? Well, this is from a figure from the guidelines where they say, let's look at the number needed to treat to reduce a cardiovascular event based on their baseline risk. And they assume that there's a 35% risk reduction if you started a moderate stent, which means that if your 10-year risk was 10 and you're at a 35% risk reduction, your absolute risk reduction is 3.5%. And therefore, the number needed to treat is 100 divided by 3.5. And so that's going to be roughly 30 or so. And that's why you can see that red dot by the 10-year event rate on the left-hand side is around the 30s. And obviously, as your baseline risk gets lower and lower, there comes a point where you need a higher number needed to treat. Now, it crosses this horizontal line, which is the number needed to cause diabetes. and that's 100 people. Um, and I think that's crazy. So the problem with that assumption is causing diabetes is not equivalent to preventing a cardiovascular death or myocardial infarction or a stroke. Secondly, as we heard, very nicely in the prior talk, the diabetes threshold is an arbitrary cut point. Statins do nudge up hemoglobin A1C by about 0.06 to 0.08%. They don't cause someone to have diabetes. They shift the A1C a tiny amount. So the people who were pre-diabetes then are nudged up slightly beyond that threshold, and therefore they suddenly become someone with diabetes, but their A1C is trivially different there. We know, and we heard nicely in the talk before, if you have diabetes, we have a bunch of therapies, GLP-1 receptor agonists in particular, that lower cardiovascular risk. So now these people would actually qualify for a new therapy that could reduce their cardiovascular risk. And if you're concerned about this increase in A1C, ezetimibe, bempedoic acid, and PCSK9 inhibitors do not increase that risk. So I think for these individuals, they have these targets here of 100 or so. These people, I think, should all be under 70. So let me wrap up. So I think for the ASCVD continuum, there's people with no known ASCVD and those who have known ASCVD. And you can subdivide them into these groups. The guidelines for the ESC and the US guidelines are very complicated. I think it can be far simpler based on the data we have. If you have atherosclerosis or if you have diabetes and you're high risk, you should be under 40 milligrams per deciliter. We've shown that in Fourier and Vesalius. Other than that, you don't want them to develop atherosclerosis and simply target under 70 milligrams per deciliter. I'll stop here. Thank you very much for your attention, and I look forward to the discussion later on this evening.
Thank you very much, Professor Sabatin. Now, you just made it quite easy, less than 70 and less than 40. I think that would make it very easy for practitioners to decide on targets. Now, would like to have around 7 minutes break for Maghrib prayer, and then we'll resume exactly in 5 to 7 minutes. Thank you very much. Assalamu alaikum wa rahmatullah, and welcome back. Hope everyone is back from prayers. Now, our next speaker is my friend and younger brother, Dr. Alamin Abdelgader. Dr. Alamin is a consultant endocrinologist at Dubai Hospital. He's an associate professor of endocrinology and internal medicine at the MBRU, Mohammed bin Rashid University in Dubai. He's a fellow of the Royal College of Physicians, fellow of the American College of Physicians, and the American College of Endocrinology. He is certified in thyroid ultrasound, and he has interest in the metabolic part of endocrinology, where he is interested in obesity and management of dyslipidemia. He has published more than 100 peer-reviewed articles in well-known journals. Dr. Alamin today is going to discuss the other part of dyslipidemia, where he is going to focus on management of hyperlipidemia, when to intervene. Dr. Alamin, the floor is yours.
Thank you very much, Dr. Ala, for the very kind introduction. It's a great pleasure and honor to be here again in the second wave of the Emirates Diabetes Society Dyslipidemia Masterclass. And I'd like to thank Professor Hassanein, Professor Sabatin for paving the road towards the management of hypertriglyceridemia. Professor Hassanein led the foundation of cardiovascular risk assessment, and Professor Sabatin very elegantly ran through the evidence of management of LDL and how aggressive should we go in terms of treating high LDL in people at very high risk and other categories as well. And I've been given the task today to cover the hypertriglyceridemia part, and what I'll be going through over the coming 20 minutes or so is just
I mean, your voice is
the cardiovascular risk evaluation in people with hypertriglyceridemia, when and where to intervene. Am I coming through normally? Is
yes.
it
Now it's
audible
back.
now?
It's back. Yes.
Okay. Okay, thank you very much. So this is my disclosures, and what I'll be doing in the coming 20 minutes or so is to go over the burden of dyslipidemia, hypertriglyceridemia specifically, and cardiovascular risk assessment in people with high TG, and a couple of insights from the international guidelines. So from one of the Asian population-based studies have quantified the prevalence of hypertriglyceridemia at different age groups. Hypertriglyceridemia is quite evident in males. Almost 40% of adult males, they are living with hypertriglyceridemia, compared to around 30% in women. And as we can see, the middle age group are the people who are the most prevalent with hypertriglyceridemia, and this is probably where the guidelines focuses the most, that we need to appropriately risk stratify those population and treat them appropriately. The more global data have shown more or less the same in terms of hypertriglyceridemia in the top left side of the graph, where the global prevalence of hypertriglyceridemia is somewhere around 30%, and again with male predominance. And as we can see here is the latest evidence from the year 2020 to 2025 is around 29% of the global population might be living, adult population might be living with hypertriglyceridemia. And if you look at the bottom right part of the graph, is the prevalence of the high LDL, where it shows around 16%. And probably this is because of the intensive recommendation, and always the discussion is around how stringent should we go in the LDL targets, and we tend to forget about the triglyceridemia. And probably again, because of the dynamic nature of the relation between hypertriglyceridemia and cardiovascular disease. As you all know, we've been through different waves, whether the hypertriglyceridemia is a robust cardiovascular risk factor or not, but the latest evidence have shown and confirmed that it is a cardiovascular risk factor. So zooming out of the LDL, and as you all know now, the guidelines are more focusing on the non-HDL cholesterol, which we deduct the total cholesterol, we deduct the HDL out of the total cholesterol, and we end up with the more atherogenic particles or components of the blood cholesterol. This cartoon describes the different particles of the lipids in the circulation, and this probably most of you have seen the same cartoon in different format, but the yellow component is the cholesterol component of different lipid particles in the serum in the blood circulation. Excluding the HDL, we end up with LDL, intermediate density lipoprotein, very low density lipoprotein, and the chylomicron remnants. The higher the density or the size of the lipid particle, the less atherogenicity, but yet they do contain a yellow component, which is the potential atherogenic part of these lipid particles. So the higher the density, the less atherogenicity. Yes, atherogenicity, but they do still have some cholesterol particles that may end up with being a potential atherogenic particles. And the lower the density and the size, the higher the atherogenicity. And we all know that the LDL is the most atherogenic part of the common lipoproteins, and excluding the genetically determined lipoproteins. So the lower the particle, the lower the density, the higher the atherogenicity in the long-term outcome. So taking the yellow component, if we can say, which is the cholesterol component of the different lipid particles, we end up with the total atherogenic particles circulating in the blood circulation. More importantly, now we are going even deeper into what's called the remnant cholesterol. By excluding the LDL, we end up with the particles that they don't usually be measured directly, because we do measure the VLDL, we can measure the IDL, we can measure the chylomicron remnants, but we cannot measure those components of the LDL, the atherogenic component of those particles. So all in all, they are called the remnant cholesterol, which is the total cholesterol minus the LDL minus the HDL cholesterol. And this, we will come to that in a minute in the pathogenesis of ASCVD. This is a very busy slide, but I would like to take you backwards to the physiology and pathophysiology of hypertriglyceridemia in order to understand what could be the outcome of that. So dissecting this busy slide into smaller ones, we have two routes through which we get the triglyceride and the chylomicrons, and then the outcomes of those two particles. The external source is usually the dietary fat, and that should be or would be absorbed into through the gut wall into the circulation in a form of chylomicrons. And these chylomicrons, after being digested or taken out of the external sources, which is usually the dietary fat, and it's of importance to currently very popular in this part of Asia in general. It's very high and rich in triglyceride. So specifically, we should be cautious about that. So having the external source of the chylomicron, this chylomicron through the peripheral lipoprotein lipase will get into chylomicron remnants, and this will further either be taken up by the liver, and we had more than what it should be in the circulation, or if we have a defected lipoprotein lipase, we will have a hyperchylomicronemia, and this hyperchylomicronemia is one of the very known causes of acute pancreatitis. And it doesn't stop here. So if we have a more hyperchylomicronemia, normal lipoprotein lipase, but the liver cannot take up the overproduction of the chylomicron remnants, the remnants are very small compared to the chylomicrons, and they can go through the pores of the blood vessels and being taken later by the macrophages, leading to foam formation, and could be also one of the causes of atherosclerotic cardiovascular disease. And this is exactly what we've just been mentioned, that the triglyceride and the chylomicrons, when they are degraded into the remnants, and remnants are very small particles that can pass through the blood vessel, leading to the foundation of future atherosclerotic cardiovascular disease. That was the external source, which is basically the dietary one. What about the internal source of the triglyceride and the triglyceride remnants? And we all know that the VLDL is a triglyceride component that contains some cholesterol, and it's the largest of the lipoproteins here. Then it comes from the liver, but there are some boosters to provide this. Again, dietary fat might interfere with that. The dietary fructose is one of the most important sources for endogenous production of triglycerides, insulin resistance, and some genetic mutations as well. So this VLDL, which is internally produced, will be through the peripheral lipoprotein lipase degraded into IDL, and in the end, LDL, which we all know that, again, if it is more than what the liver can take, or if we have any mutation in the LDL receptors, again, this LDL will go through the vascular pores and lead to future atherosclerotic cardiovascular disease. One of the important enzymes that facilitates or orchestrate the production of VLDL is the ApoC3. And probably most of you have heard of the ApoC3 inhibitors, the new medications that has been extensively studied over decades. And the more this ApoC3, the more production of VLDL, and then IDL and LDL and remnants, leading to atherosclerosis, especially if we have a congenital or genetic determined abnormality. So blocking this enzyme might minimize production of VLDL and the consequent atherogenic particles. And it's important to note that the higher the triglyceride level, the higher the amount of the triglyceride remnants. And we've just mentioned that the remnants are more atherogenic. So the more we go through the triglyceride level, and this is in millimoles, which is the higher the level, the higher the risk of the triglyceride remnants prevalence in circulation, or level in circulation, and the higher risk or likelihood of future atherosclerotic cardiovascular disease. So for those who have been in practice for 2 decades or more, probably you are acquainted with the time where we had some less confidence that the triglyceride itself is a robust cardiovascular risk. But we have now more than meta-analysis and very large trials that have shown the higher the triglyceride level, the higher risk of cardiovascular disease in people with normal LDL cholesterol. So the more you go with the triglyceride level, the higher the prevalence of the atherosclerotic cardiovascular disease, 40% up to 60+% for patients with extensively high the triglyceride level. And this has been replicated in multiple meta-analysis as we've just mentioned. And the important point is that the risk stratification or risk factor of atherosclerotic cardiovascular disease doesn't start at 150 that we usually have it as a cutoff point. It actually starts here somewhere around 70 milligrams per deciliter, where you can see the overall mortality increases, the cancer mortality slightly start to increase, but the cardiovascular mortality specifically start to increase from the triglyceride level somewhere around 70 milligrams per deciliter. We have, as we've mentioned, either the metabolic syndrome related hypertriglyceridemia or familial or genetic hypertriglyceridemia. In addition to that, we have a very long list of acquired hypertriglyceridemia as well. The most important are the alcohol intake, high sugar intake, specifically the fructose. And this takes us to the point that the fresh juice is always the best thing to have. It's very rich in fructose, and it's a direct fructose that will be taken up quite fast. Sedentary lifestyle, and as the Professor Hassanin alluded to in the earlier part of this session today. And overweight and obesity, metabolic syndrome, pregnancy, especially late in pregnancy, and weight gain are the most important ones. In addition to lots of medications that we do take on the daily basis, including beta blockers, steroids, diuretics, and multiple anabolic steroids and androgens and estrogens. Some diseases like poorly controlled diabetes, rheumatoid arthritis, psoriasis, and SLE are also associated with hypertriglyceridemia. Just to note that this is this form is called North American Familial Hyperchylomicronemia Calculator, which is the NAFCS risk score. It's actually used to filter the patients with hypertriglyceridemia and to identify those who are with genetically determined hyperchylomicronemia, which is the familial type. And we all know that the familial type is more having more negative impact and has to be treated aggressively to prevent both pancreatitis and atherosclerotic cardiovascular disease on the long run. We use this form for people with severe hypertriglyceridemia despite at least one treatment for hypertriglyceridemia, or youngsters at 10 years or less with high triglyceride level. Then we need to adopt this NAFCS screening tool. In other way around, we can use it for all patients with hypertriglyceridemia if needed, but for just the familial chylomicronemia is not a very common condition. However, we need to identify it whenever there is high risk of that. This is a European form, style of the form, which is more or less the same. They are readily available in the internet for whoever wanted to try them. Okay, so we've gone through the physiology, the pathophysiology of the hypertriglyceridemia, identifying the familial causes of hypertriglyceridemia, and I hope we agree now that the hypertriglyceridemia is a robust cardiovascular risk factor and it needs to be tackled quite aggressively. So the foundation of hypertriglyceridemia management is always lifestyle intervention and appropriate correction of high LDL level. So the lifestyle intervention plus statin initiation is the foundation of management of hypertriglyceridemia. We don't usually jump immediately to anti-hypertriglyceridemic agents. And with lifestyle intervention is similar to most of the metabolic syndrome recommendations. Just avoid drinking any sweetened beverages, minimize alcohol, minimize sweets, avoid the ultra processed food, and avoid the corrective for those who are having high triglyceride level despite treatment. And add more vegetables, more fish, nuts and seeds and legumes, and olive oil, sort of Mediterranean type food is quite recommended. And always eat and socialize with people where the portion of the food will be lower. Drink water before and after a sweetened or salty food. And as much as possible, eat from home cooked food, not from the fast prepared options. I'll go in a bit of details through the 2026 ACC guidelines, and Professor Sabatin have alluded to in the LDL component. And here we can group the categories that the ASCVD patient with ASCVD and hypertriglyceridemia, and the fasting triglyceride more than 150 milligrams per deciliter, but less than 500 milligrams per deciliter. And the non-fasting, we can go up to 175 as a cutoff point. While patients with diabetes and age more than 40 years without ASCVD and hypertriglyceridemia, and the category of patients without ASCVD or diabetes, and again, the cutoff point is more than 150 milligrams per deciliter. So for all those categories, if the triglyceride is more than 150, the first thing to do, as we've just mentioned, lifestyle intervention and statin therapy. And this is the summary of what's been mentioned here. Even for those with severe hypertriglyceridemia, which is more than 500 milligrams per deciliter, and especially for those with very severe hypertriglyceridemia, which is more than 1,000 milligrams per deciliter. And this is where the threshold for diagnosis of familial chylomicronemia is quite high. So between 500 to 1,000 is a severe hypertriglyceridemia. More than 1,000, almost always consider the familial component of this pathogenesis. So lifestyle intervention plus statin therapy is the foundation of treatment. If it's persistent, then consider the triglyceride dedicated medications afterwards. Okay, dissecting them into several categories: people with ASCVD and hypertriglyceridemia. As we've mentioned earlier, lifestyle intervention, including avoidance of ethanol, healthier lifestyle in terms of more activity, less sedentary life, avoid the fried and fast food as much as we can. And the first point to do pharmacotherapy, from pharmacotherapy point of view, is to start high intensity statin to reduce the LDL to the optimum level. If we manage to grab the LDL less than the target that we're looking for, and still the triglyceridemia is quite persistent, then we may consider the icosapent ethyl for cardiovascular protection. This is the high to very high risk of future ASCVD. So the option of hypertriglyceridemia that we have in hand now that has proven evidence to reduce the cardiovascular event is the icosapent ethyl. While the other anti-hypertriglyceridemic medication have failed to proven the cardiovascular protection. So this graph says that always start with lifestyle intervention, statin optimization to the least possible LDL target that we can achieve based on the ASCVD category. And then if still we have a triglyceride more than 150 milligrams per deciliter, the only option here to reduce the cardiovascular event is icosapent ethyl, and this was have been just mentioned earlier. So what about the category with hypertriglyceridemia but without ASCVD or dyslipidemia? Again, lifestyle intervention, avoidance of alcohol and fast food. Then if the triglyceride is still more than 150, those patients, we don't jump to start the treatment, but we put them into the prevent ASCVD risk stratification engine. And if they are at high risk, then start with statin again. If then not controlled, then we can consider anti-hypertriglyceridemic medications. But also for those patients, the statin is the foundation of treatment to reduce both LDL and triglyceride. And it's important to note that high-intensity statins reduce the triglyceride between 20 to 40%. So by adding these statins, we may as well improve the triglyceride level. What about the general population with hypertriglyceride more than 500 milligrams per deciliter? Again, lifestyle intervention is the first to go. Then prevent risk stratification engine, and this prevent is from the American guidelines, and we have several other risk stratification engines from different parts of the world. So if the patient is having high risk of future cardiovascular disease, again, optimization of LDL. But here, if we want to control this triglyceride of more than 500 milligrams per deciliter, we can use any antihyperglycemic medication, hypertriglyceridemic medication, including fibrates or the prescription-based omega-3. And in case we have sort of high likelihood of having genetic determined hypertriglyceridemia, then the newer medication was which is olezarsen lowers the triglyceride level quite significantly in people with familial hyperchylomicronemia or genetically determined hypertriglyceridemia. So in case that just severe hypertriglyceridemia and no much of cardiovascular risk, then all antihypertriglyceridemic medications can be an option of treatment. And what the European Society of Cardiology guidelines said, and probably Professor Sabatine have made some comparison between the two guidelines, and yet at several points, the European Society of Cardiology guidelines, despite being published a couple of months before the ACC guidelines, but they are ahead of the ACC guidelines in terms of several areas. And this is one of them, that in patients with hypertriglyceridemia and at high or very high risk of cardiovascular disease, statins and hypertriglyceridemic medications should be started as soon as possible. And here again, it's icosapent ethyl, which is the only medication that proven the cardiovascular protection. And they have also alluded to the other group of olezarsen, which is called the volanesorsen. That's one of the new medications, again, for the severe hypertriglyceridemia or the familial hypochylomicronemia. What about the standards of diabetes guidelines? They have mentioned the same, more than 150 milligrams per deciliter in patients with ASCVD or other cardiovascular risk factors. Start with antihyperglycemic medications, and they have mentioned here also the icosapent ethyl as the only cardioprotective agent in this field. ACE guidelines since 2023, very busy slide, just focus on this orange part, please. That as the triglyceride level goes higher, the first option is intensifying the lifestyle and glycemic control. And then if the target here more than, and the European Society of Cardiology guidelines, they agreed on the 135 compared to 150 milligrams per deciliter in the ACC American guidelines. And why is that? That because the main landmark trial of hypertriglyceridemia is called REDUCE-IT, and the cutoff point of entry was 135 milligrams per deciliter. So this has been adopted by ACE and the European Society of Cardiology guidelines. So if we have the patient with ASCVD or diabetes and other cardiovascular risk, consider icosapent ethyl as cardioprotective agent here as well. So with that, Mr. Chairperson, dear colleagues and friends, please allow me to conclude that dyslipidemia is widely prevalent disease. We need to actively screen and manage it as early as possible. Hypertriglyceridemia increases the risk of ASCVD and pancreatitis. Non-HDL cholesterol is an integral part of ASCVD risk management or assessment and a driver for choosing which treatment to tackle. In ASCVD, LDL lowering is the mainstay, then residual risk of non-HDL cholesterol comes after. Lifestyle intervention is the foundation of management of hypertriglyceridemia as much as many other metabolic disorders. The ASCVD reduction using icosapent ethyl is the only proven option to reduce CVD in hypertriglyceridemia. For pancreatitis risk reduction, we can use any one of the options, fenofibrates, omega-3, olezarsen. In severe familial hypertriglyceridemia, olezarsen has been FDA approved. And to come in the near future, the injectable ApoC3 data promising to reduce the triglyceride level by 80%, and fingers crossed to have this in clinical practice soon. With that, I'd like to thank you very much and happy to join again the Q&A session.
Thank you very much, Dr. Alamin. Quite elaborative. And with that, we've covered the management of LDL cholesterol as well as the hypertriglyceridemia. So our next talk is by Dr. Juwairiya Al-Ali. Dr. Juwairiya is a consultant, non-invasive cardiologist at Rashid Hospital at Dubai Health. She is the president of the Emirates Cardiac Society and the first woman to hold this position in the Arabian Gulf. She's the program director for the Adult Cardiology Fellowship Program at Dubai Health and MBRU. And she is the one leading the curriculum development and the academic training. She is the chair of the Cardiovascular Disease in Women Conference and an active member of the Women Cardiovascular Research Consortium in the MENA region. She has an extensive experience in heart failure management, leading the Heart Failure Foundation Function Clinic and contributing to multiple advisory boards. She has shared as well in multiple UAE guidelines, and Dr. Juwairiya is going to discuss the guidelines in a case-based manner. Dr. Juwairiya, you're welcome, and the floor is yours.
Thank you, Dr. Ala, for the kind introduction. And I feel humbled following all these excellent speakers ahead of me. They had really a more challenging part. My part is simple and also entertaining. So this is going to be a clinical scenario, and there's going to be audience response questions. So I would want you to participate in this. So we can work through this case and see what we would do for this patient. The title that I was given is Guideline-Based Clinical Scenario. One shoe doesn't fit all, but in this situation, I have like a really long case. But you will see that for this foot, we could have used multiple different shoes. So the reason I put in the atheroma progression, I think this is something important that we need to remember when we're treating lipids. We're not treating LDL number, we're not treating triglyceride number, we're treating atherosclerosis. And I think it's important that we remember that and that we remind our patients of this. I know a fellow endocrinologist told me that he has this atheroma progression graph in his clinic. I'm a cardiologist, so I use the angiogram. So that's how I get patients invested into treating their lipids, because as you all know, LDL cholesterol is asymptomatic by itself. If the LDL goes up, the patient does not feel anything. So we really need to have to link it to the clinical disease for the patient to understand the importance of it. So we'll go to the case history. This is a real case. It's a messy case. It's something that you probably have seen in your clinic, but it helps us work through lots of the concepts that was already covered tonight. So it's a 56-year-old male. He's known to have type 2 diabetes for only 4 years, an HbA1c of 7.3, normal creatinine and no microalbuminuria. He's obese with a BMI of 34. He has dyslipidemia. He's a smoker. And his blood pressure is 143/86, but he's not labeled to be hypertensive. So if you look at his total cholesterol is 186, triglyceride is 671, HDL is 21, and LDL is 78. And surprise, he's not on any lipid-lowering medication. He's only on empagliflozin 10 milligram and a B complex. So this is the first audience response question. What is the cardiac risk for this patient? Is he a low risk, intermediate risk, high risk, or very high risk, or extreme risk? If we can just put the poll for the audience so they can answer. So I'll give you a minute and let's see what would you choose. I don't have a countdown, so if we have enough numbers, maybe we can look at the results of the poll. Okay, good. So 47% said high risk and 25% said very high risk. Probably these two groups are the most correct one. We have 20% who said intermediate risk. So let's look at, I mean, when we calculate the risk, there are risk calculators, right? And this is what we should do in the clinic. If we just look at the patient and assume the risk, sometimes we underestimate it. A lot of times, actually, we underestimate it. So we've seen from the talk from Dr. Hassani, there are multiple risk calculators. So if you calculate the score 2 risk score from the ASC, it's put him at 24% risk of cardiovascular events. So that's very high risk. If you use the prevent score from the AHA, it puts him at 21.8. So if the prevent score doesn't have a very high, so it's high risk. If you use the UAE guideline score, so he will have score 1 for age above 40, and then he will score 2 for multiple comorbidities because he's obese and a smoker, and also hypertensive, but I mean, not labeled, but he's hypertensive. Then that would put him at a high risk. So, so these are this is the UAE cardiometabolic guidelines. So as we said, this for this patient, he's about the age of 40. His duration of diabetes is less than 10 years, so that's gives him 0, but he has multiple cardiovascular risks, so that's going to be 3. And that with 3 puts him at a high risk of cardiovascular disease. We calculated his risk by the score 2, so score 2 was more than 20%, so you see that put him at the very high risk group, regardless of his duration of diabetes. And that puts him for a class 1A recommendation for a target LDL less than 55 or 50% reduction from his baseline LDL. And remember, this patient came in with no statin on board. So you have a baseline LDL for this patient. So an extreme risk patient is only mentioned in the ASC guidelines, and it's someone who has recurrent vascular events while being on a maximum tolerated statin or a polyvascular patient. So obviously someone who is in the secondary prevention, not the primary prevention group. And so far, this patient is still in the primary prevention. So with the score 2, as he said, it was more than 20%. So that's a very high risk patient. And it's almost as if he has established ASCVD. So what is the recommendation for LDL lowering? So for the ASC guidelines, very high risk patients should go less than 55 milligram per deciliter of LDL and 50% reduction. High risk patients should go less than 70 milligrams and 50% reduction. So if you remember, this patient had an LDL of 73 or 74. So a 50% reduction will bring him significantly lower than 55. So even if you said he's high risk, not very high risk, still his target is significantly lower. And the ADA, someone with a high risk in the ADA guidelines will have a target of less than 70 and a 50% reduction. So always remember the and a 50% reduction, because we forget that. We remember the number and we forget the and. So what is your next step in the management? Would you start a statin or start moderate intensity, start an aspirin, start moderate intensity statin, start high intensity statin, or start icosapentael ethyl for high triglyceride, or you do 1 and 2 aspirin and moderate intensity, or you do 1, 2, and 4 aspirin moderate intensity and icosapentael, or you do 3 and 4, which is high intensity statin and icosapentael ethyl. Can you please vote? I know it's a little bit complicated, but the case is like this. I try to make it easier, but this is what goes through your mind when you're looking at a patient like this. You have multiple issues. You have an LDL that's not treated. The patient is not on statin anymore, and he's a high risk, and he has an elevated triglyceride as well. So you have the poll, so you can answer. And I don't expect like the best possible answer. This is more to think about it together, because as you will see when I show you the case, it didn't go how I would have treated it, but this is how it went, you know. So it's important to think about how we would treat this patient. Okay. So, wow, we have significant split. So we have the majority, 28% said they're going to start this aspirin, moderate intensity statin, and icosapentile ethyl. Okay, 26% they said they're going to start high intensity statin, and then 20% said they're going to start high intensity statin and icosapentile ethyl. So if we remember the talk that Dr. Al-Amin gave, he gave an extensive talk about treating hypertriglyceridemia. And the number one thing is that you need to treat the LDL first. So it's a stepwise approach. You don't treat them together. So the ideal answer in this situation would be to start high intensity statin to begin with, because this is a high risk patient and you want 50% reduction, and you will not get 50% reduction with moderate intensity statin. You'll only get it with a high intensity statin. Now, the issue of aspirin, should you start it or not? It's a primary prevention case. There isn't very strong evidence to start statin in such a case. It could be a joint discussion between you and the patient, given that you know that he's a high risk. So it's an option to add, but I think the clear answer would be to start a high intensity statin. So what happened for him? So this is you've seen this guidelines before. So patients with diabetes without ASCVD, this is from the AHA guidelines. If they have a high prevent score, they should start on a high intensity statin with a goal of 50% reduction in LDL. And as we said, you only get 50% reduction with high intensity statin. With moderate intensity statin, you're only gonna get 30% reduction. And you've seen this, I'm sure, in the guidelines. Anything 50% or above, it's going to be either high intensity statin or with a combination of ezetimibe or with a combination of the PCSK9 inhibitor or therapeutic acids. And these are just for you to remember. High intensity statin, you have two options: atorvastatin 40 to 80, rosuvastatin 20 to 40. Anything other than that is moderate intensity statin or a low intensity statin. So these are the options. You want to start with 40 atorvastatin, that's possible because that's high intensity, so 40 to 80, or rosuvastatin 20 to 40. So what was the patient started on? So he was started on moderate intensity statin. So he was on rosuvastatin 10 and bisoprolol 2.5. I mean, he's diabetic, his blood pressure was high. I'm not sure that would have been my choice of an antihypertensive, but that's what he was started on. So this is, this is not actually my patient. This is a patient on the system. So I thought it's interesting to see how he progressed. So a year later, he presented with atypical chest pain. So actually 3 cardiologists. The first person put him on a treadmill test, and he did well on the treadmill test, and he was fine. And then he got discharged with no change in his medications, what I think is also a responsibility on cardiologists. Like, we don't just exclude chest pain, but we should actually intervene on the preventive treatment when we see him. And then presented again with atypical chest pain. So the next person who saw him said, you know what, we're going to do a CT angio. And this is his CT coronary. So he has, so this is, I don't know if you see my marker. I have a laser pointer. So here you go. So this is the left main, and this is the LAD. So this is the main artery that comes down in the front of the heart. This is the widowmaker, as we call it. If you have a blockage in this artery, you die. So he had a plaque, a mixed plaque in the distal left main to LAD. This was reported as soft plaque with some calcifications and around 65% stenosis. There is also a med LAD plaque as well. So now this patient has coronary artery disease. So what is the target LDL for this patient? That's the next audience response question. Is it less than 100, less than 70, less than 55, less than 40, or less than 39? You can vote on that. Okay, maybe if we can get the answers. Oh, wow. Okay, so 45% says less than 55. 26% said less than 40. Only 4% says less than 39. So this is an ASCVD patient. So he has plaques in his coronaries. He's diabetic, and we already established that he's very high risk. We need 50% reduction from his baseline LDL, and his baseline LDL was 73 or 74. So you need 50% reduction from that. So that takes you to less than 39. So his target should be less than 39. This is why it gets confusing, right? Because it's easier to remember the number 55, 40, but actually his target is less than 39. Okay. So again, remember, you need 50% reduction from baseline. I'll get the laser pointer here. So 50% reduction from baseline from high risk and above. So the high risk, very high risk, and extreme risk, you need the 50% reduction and the target, whatever is lower. So in this case, you need to go 50% from his baseline LDL. So seen a year after. So after a year, his hemoglobin A1C now is 7.5. His triglycerides is 1,635. And his LDL is 65. For some reason, no one escalated his rosuvastatin, so he's still on 10 milligram. He's on empagliflozin 20 milligrams daily. He's on aspirin 100, bisoprolol 2.5, and someone added fenofibrates for him. So he's on fenofibrate 145 milligram per deciliter. His BMI is 40 now, it's increased. His blood pressure is better, it's 106 over 80. So how would you change his management? That's another audience response. So would you refer him to bariatric surgery and start a GLP-1 agonist, increase a statin to high intensity, add ezetimibe, stop fenofibrate, or add icosapentad ethyl, or you do 1 and 2, or you do 1, 2, and 3, or you would do 1, 2, 3, and 4, or we do all of the above? I'll give you, I know, lots of options, but just think about them. You have a triglyceride of 1,600, almost. LDL is not at target. He's at 63, I think, or 65. And he's also obese. His BMI is 40. Well, we have a widespread. So, but I think the majority said all of the above. So I think referring him to bariatric surgery and starting a GLP-1 agonist is an important thing. Increasing statin to high intensity is a good option. Adding ezetimibe is also a good option because you want to get lower is better in this patient, and he's a high-risk patient. Stopping fenofibrate, yes. I mean, if I was the one managing the patient, I would stop it because you don't have benefit. You don't have evidence of cardiovascular benefit, and you have other agents that need to be optimized before adding fenofibrate. Adding EPA, ideally you would wait for the results of increasing statin to high intensity and add an ezetimibe, but I think with a triglyceride of 1,600, you're not going to get there with just high intensity statin. So I think it's reasonable to add AP as well. So what happened with him? So he was started on a high intensity statin and ezetimibe combination. Now remember, this is almost 3 years after his initial presentation. So it took him 3 years to get to where we should have been on day one. Day one, he should have been on a high intensity statin. And this is the problem with managing dyslipidemia. We all know the targets, we all heard the trials, and we know what we're supposed to do, but yet in real life, it takes us very long time to get there. He was also started in EPA and referred for bariatric surgery. 1 year later, he was tried on a GLP-1 agonist, but he didn't tolerate it due to gastric symptoms. Now his HbA1c is 9, his LDL is 99, and his triglycerides is 405. So there's something wrong going on. Like LDL is higher than when we started. Triglycerides better, and HbA1c is significantly worse. So what's your next management plan? Would you discuss compliance issue, or would you add PCSK9 inhibitors, or would you do 1 and 2? That's an easier question. One and two. So 67% said 1 and 2. Actually, we did 1 and 2. But knowing how the case progressed later on, I would tell you, like 2, I don't know how much PCSK9 did in someone who has issues with compliance. So this is the problem. So one of the problems in this case is it took us so long to get to where we're supposed to be. And once you take too many changes and medication, too many visits to get there, compliance goes down. I don't think that was the only factor in this case, but I'm sure it's a contributing factor. Of course, there is patient-related factors, patients who don't have poor perception of their disease, they are unaware of its importance, they don't do frequent testing. There's also the complexity of the therapy that they're taking and fear of side effects. But compliance is a major issue here. And I think it's the thing that's driving all of this. He had a lower LDL with a medium intensity statin than with a high intensity statin. So he's not taking his statin. That's very clear. And if you look at his trend of LDL over the years, you can tell that it goes down. Like if you see the trends of the studies, it goes down and it stays down. But here it goes down, goes up again, and then goes down and goes up again. That means he's not taking his therapy. The trend with triglyceride is the same. Goes down, up, down, up. So when you catch him on an up, you think, oh my God, he's more than 1,000. His triglyceride more than 1,000. But he actually goes down to around 500 and 400 in between whenever he takes his therapy. And his HbA1c suffered over the years because of non-compliance. So over the years, his HbA1c is increasing. So looking at another patient, just because I was supposed to show you a really good case and I showed you something that didn't go as planned. But if you look at another patient, this is a 45-year-old patient post-ACS who was started on a high-intensity statin. And with the high-intensity statin went down. With high-intensity statin went down to around 55 of LDL. And then here we had the addition of PCSK9 inhibitors. So he went down to below 20 of LDL. And then decided not to take his statin. So it went up again. Then he was reminded to take his statin and went down again to below 20 of LDL. So the medication works only if you take them. The medication works only if you take them in the proper way. And someone with ASCVD, most of the time you would need PCSK9 and high-intensity statin to achieve your target. You cannot achieve the target only with a PCSK9 inhibitor. So I think the takeaway message from this is risk stratification can change your target. If you remember, guys, when we first put the case, if you didn't do the risk calculator, some of you thought this is an intermediate risk patient, where he was a high risk or very high risk patient. And it does change how you manage the patient. And in this case, it was missed for 3 years. Frequent measurements can't establish compliance, and this is very important. The fact that they come to you and see you and you see all the labs are good, that's a good thing. That's what you want to see, because if they don't come and they don't test, then you don't know if they're taking the medication, especially that it's not a disease that produces symptoms immediately. And joint decision-making is key in managing patients. If the patient is not on board, no matter what you give them, the numbers are going to be off the chart. So with that, I will end my talk, and I'll be staying on for the question and answer part later on.
Thank you very much, Dr. Juwairiya. Quite challenging case, and it actually highlights the importance of early intervention and ensuring the compliance in those patients. I'd like just to remind the attendees that the symposium is on demand at the EDS Institute website. So whenever you would like to get back to the symposium to review the talks, then you can get to the website. Our next talk is a symposium for Amgen by Professor Giuseppe. He's a senior consultant in cardiology and the director of the cardiology division at Turin, Italy. He's a renowned intervention cardiologist with extensive experience in coronary and structural heart interventions, including high-volume angioplasty and minimally invasive procedures. He's the past president of the Italian Society of Intervention Cardiology and the regional president of the Italian Society of Cardiology. He is an active leader of within the national cardiology networks, including roles such as regional president of the Italian Society of Cardiology. He has published many papers in peer-reviewed journals, and he is here to talk about the evolution of LDL management, the new evidence, and the new opportunities. Professor Giuseppe, the floor is yours.
Thank you very much for the invitation. Good evening to everybody. It's a pleasure for me to be here with you. Now I start with my slides. My topic is the evolution of LDL management, and what about LDL? In these slides, that is a very old slides, more than 20 years old slides, we can see that there is a linear correlation between LDL levels and prognosis of the patients, a linear correlation between LDL and cardiovascular events. If we decrease LDL, we can decrease events, and these are old slides. In fact, we arrive until 50 milligrams of LDL with IMPROVE-IT trial, and then statin plus enzalutamide. And in these other slides, we have the explanation of the first slides. In these slides, we can see the same linear correlation between LDL and plaque volume studied with intravascular ultrasound. We can see that if we have a reduction of LDL, we can have a reduction of the plaque volume, and then we can stop the progression of the plaque until we can propagate the regression of the plaque. And now with the data of PCSK9 inhibitors, especially evolocumab, we can see that there is no limit in the reduction of LDL and the linear correlation between LDL and prognosis. We know from the data by Bob Giuliano from the sub-study of Fourier that if we go under 10 milligrams of LDL, we have still a reduction of MACE. And then we can change the prognosis of the patients because we can change the natural history of the atherosclerosis. We know that the atherosclerosis starts when we are young. There is an increase of the volume of the plaque until the plaque became unstable. There is a fracture of the thin cap fibrous atheroma until there is the clot formation, and acute coronary syndrome. And then what about the new guidelines, the ESC guidelines, as mentioned before by the colleagues? Now the patients that have atherosclerosis, also subclinical atherosclerosis, are very high-risk patients, and the cutoff is 55 milligrams of LDL. And for diabetic patients, we know also that if the patients had no atherosclerosis but have another organ damage, or the diabetes more than 10 years, or another risk factor, for example, diabetes and hypertension, the patient is high risk, and then he have 70 milligrams of LDL. Of course, all patients with atherosclerosis, clinical imaging, and of course, patients with angioplasty or sub-intervention had as target 55 milligrams. And patients with multivascular disease, for example, coronary artery disease and peripheral artery disease, or more than one event in the life, are at extreme risk with cutoff of 40 milligrams. And disease is completely different compared with the old guidelines, because we remember that in the old guidelines, the patients at extreme risk was the recurrent events, patients with more than 2 events in the last 2 years. Now, if the patients had more than 1 event in the life, or he had a polyvascular disease, coronary and peripheral artery disease, is at extreme risk, and the guidelines are very clear. Why? Why? Because we know that after one event, the risk or another event is very high, especially in patients with diabetes. If the patients had a diabetes, also without a prior event, the prognosis is completely different compared with patients with diabetes. And we know that there are a lot of problems in our clinical practice, a lot of gaps, because 20% of patient survivors to HES achieve another events. We fail in achieve the LDL target in more than 75% of patients. A lot of patients are treated with suboptimal. What about the strategy? For these patients, we know that we have a lot of drugs, and the much power drugs are PCSK9 inhibitors, especially evolocumab. As mentioned in this meta-analysis, we know from Fourier trial that evolocumab reduce MACE of 2 points in patients at very high risk. But how we can use these drugs? First of all, patients with acute coronary syndrome. In patients with acute coronary syndrome, until 2022, the recommendation of European Society of Cardiology is the strategy of strike early, strike strong, start immediately with statin and ezetimibe, and add immediately at discharge PCSK9 inhibitors in patients with high level of LDL. And then if we know that it's impossible to get the target, start immediately with triple therapy. We start with this strategy in April 2020. In my institution in Torino, we decided to start immediately with evolocumab in patients already treated with statin and ezetimibe and more than 70 milligrams of LDL. Also in patients treated only with statin, we add ezetimibe and evolocumab. And in naive patients, we start with triple therapy if the patients had more than 140 milligrams, but also in patients with more than 70 milligrams if he had another risk factor like diabetes, peripheral artery disease, or multivessel disease. And now we know that these kind of patients are extreme risk patients. Why we decide to use this strategy in this kind of patients? Because of PAD patients, multivessel patients, patients with diabetes are the patients with low, very low NNT, number needed to treat patients to avoid unevents. And what about our experience? This is the first year of our experience in 2020. We enrolled almost 500 patients with acute coronary syndrome. We can see as we start in April, as there is a reduction of statin-only therapy, an increase of combination therapy, rosuvastatin plus ezetimibe, and an increase of triple therapy with evolocumab. And we use at discharge evolocumab in 104 patients, 21% of patients who were discharged in triple therapy, the patients with high level of LDL at basal more than 130 milligrams. What about the follow-up? We can see that, of course, there is a very important drop of LDL in patients treated with triple therapy, but also a very important reduction in patients treated with double therapy. And then with the use of triple therapy in 21% of patients, we get the target in 92% of our patients. We continue during the year. This is the casuistic until 2023, more than 1,000 patients treated, 221 patients treated discharge with the triple therapy with the evolocumab, and we can see the adherence was very high, 97%. 98% of patients get the target, and as you can see in yellow, the basal LDL, in blue, the LDL at 6 months, we can see that the answer is very homogeneous, very important, very powerful in all patients. What about the Italian experience? This is the experience in 22 Italian centers that start with this strategy, strike early, strike strong. We collected the data in more than 700 patients, 771 patients discharged with triple therapy, and we can see that there is a correlation between LDL and prognosis, and the mortality is completely different in patients that get the target compared with patients that didn't get the target. The final data that I would like to show you about Italian experience in patients with acute coronary syndrome is the experience of Giuseppe Patti, very good friends, that is the president of Italian Society of Cardiology, and the registry is the fast note. He compared the strategy and the prognosis in patients with acute coronary syndrome in 3 periods. In the first 6 months of 2019 with LDL goal of 70 milligrams, first 6 months of 2021 with the LDL target of 55, but with a stepwise approach, and the first 6 months of 2023 with the target of 55, but with the strike early, strike strong approach as in our protocol. We can see, first of all, the therapy changed completely with the strike early, strike strong approach. A lot of patients treated with combination therapy, statin and ezetimibe. 23% of patients are discharged with PCSK9 inhibitors, the vast majority evolocumab. And what about the follow-up, the target? We can see that the vast majority of patients in this green period get the target compared with the other strategy. And the most important things, the prognosis is completely different in terms of MACE that are completely reduced in patient treated with strike early, strike strong approach. And now the new guidelines recommend formally in patients with acute coronary syndrome this approach. As you can see, the sentence is strike early, strike strong. The recommendation is to start immediately with a triple therapy, statin and ezetimibe in all patients. We can choose another drugs as a third drug, for example, oral drug like bempedoic acid in patients that are very near to the target, or an injective drug, Sirna, or antibodies PCSK9 inhibitors. And of course, the antibodies, the PCSK9 inhibitors, especially evolocumab, are the most powerful drugs for the reduction of LDL. Finally, now we have the data also in patients without history of an acute coronary syndrome without history or prior MI. What about the Vesalius study? It's a very important study. It's a study that enrolled more than 12,000 patients. Patients randomized to evolocumab compared to placebo. Patients at high risk but without story of myocardial infarction. And then now we move from patients with a history of acute coronary syndrome and then patients with a history of coronary disease versus patients without history of acute coronary syndrome, and then in a lot of them in primary prevention. What about all patients? We can see 67% of patients with CAD and 50% of patients with diabetes. This is the reduction of LDL, 55%, and this is the data. Very important data, 25% reduction of triple MACE, dead, MI, and stroke. And if we have a look to secondary endpoint, there is a reduction of all endpoints. Instead of coronary death, there is a reduction of cardiovascular death and all-cause death that have no statistical value because there is no reduction of coronary death. But if we have a look to the curves, if we have a look to these results, 20% of reduction is impressive. It's not statistical significant, but it's very impressive. And what about LPA? In this casuistic, we can see the reduction of MACE in patients with high level of LPA, 41% reduction, and also 35% in patients with a low level of LPA. And then we can see that especially in patients with high level of LPA, the reduction of MACE, it's impressive, 5.8 to 2.2. But the most impressive data, in my opinion, are the data about diabetes. 7,000 patients diabetes. First of all, the first sub-study are the 6,000 patients diabetes at high risk, and we can see the reduction of LDL, 62 milligrams, 52%, and disease, the reduction of MACE, almost 30%, 29%, dead, MI, and stroke. And as you can see, all secondary endpoints are reduced. This is the all-cause dead, 21% reduction. Also in this case is not statistically significant because there is no reduction of coronary death, but the data is impressive. And it is the data in all patients with diabetes, 7,000 patients. We can see 32% of triple MACE, 22% of the MACE in 4 points. But the most impressive data are patients, 3,600 patients without atherosclerosis, diabetes without clinical or subclinical atherosclerosis, the real primary prevention. And what about this data? These patients are patients 65 years old, 132 milligrams of LDL, the vast majority of patients treated with statin, a lot of patients with hypertension, and then they are very high risk patients, and the data are incredible, are very impressive. There is a reduction of 31% of dead, MI, and stroke, triple MACE in this kind of patient. There is a reduction of all secondary endpoints, a reduction of cardiovascular death, and a reduction of all-cause mortality. Also, in this case, there is not significant power because there is no reduction of coronary death, but as you can see, the curve are very important, very impressive, and you can see that Of course, the data, the benefit start after 1 year, because after 1 year, of course, there is the benefit of the reduction of LDL, but we have to start immediately as we learned from Fourier just to have this reduction after 1 year. And then with Vesalius, especially with Vesalius in diabetes, we move from atherosclerosis with a history of myocardial infarction to atherosclerosis subclinical to subclinical atherosclerosis without story of atherosclerosis, without sign of atherosclerosis in diabetic patients. Finally, I would like to show another subgroup. I am an interventional cardiologist, and then for me, these data are very impressive, is the subgroup of patients with elective PCI. The PCI percutaneous coronary intervention were performed almost 4 years before the enrollment, and we more than 3,000 patients, we can see the reduction of tribal merits of 30%. And then in this kind of patients, of course, with clinical atherosclerosis, but without history of MI, it's very important to reduce LDL. And what about myocardial infarction? The reduction is of 50% and start immediately at 6 months. At 6 months, we have a reduction of 67% of infarction. Of course, there is a reduction also of cardiovascular death, all-cause death. Also, in this case, there is no powerful in statistic terms, but the message is very important. And for this reason, in my institution, we start to use triple therapy not only in patients with acute coronary syndrome at discharge, but also in patients treated with elective PCI with the same protocol. We can see that now patients with acute coronary syndrome and also patients with elective PCI start with triple therapy if they are naive patients with more than 140 of LDL, or if they are already treated statin or with statin plus ezetimibe if they are LDL more than 70 milligrams. And then in conclusion, reduction of LDL levels correlates linearly with regression and with the prognosis. Stable patients are very high risk patients. Statin are not enough to achieve LDL. The addition of PCSK9 inhibitors, especially antibodies, can further reduction of LDL. Applying guidelines and strike strong approach, we have to treat at least 25% of our patients with acute coronary syndrome with PCSK9 inhibitors, especially antibodies at discharge. And now with the data of Vesalius, we have to start to use these drugs also in stable patients, especially in diabetic patients, also without history of atherosclerosis, in patient treated with elective coronary angioplasty. Thank you.
Thank you very much, Professor. Now, I'd like to invite all the speakers. If the previous part was interesting, I guess the next one will be more interesting. I'd like to invite Dr. Hassanein, Dr. Al-Amin, and Professor Sepatin. Now, we have so many questions, but I'll try, for the sake of time, to try to give each speaker like a single or two questions. So my first question is to Dr. Hassanein. And actually, there are two questions. I'll combine them in one. And the question says, is the cardiovascular risk calculator you mentioned in your presentation official, and we can use it in United Arab Emirates or not? And another question was the risk, the screening. They noticed that you mentioned that screening we do for, risk calculator we apply for subjects who are screen negative. So the question is, if the subject is screen negative and he's diabetic, does diabetes consider a positive screening or not? So, Dr.
So let me
Hassanin.
take thank you very much for these very important questions. So the answer to the first question is yes, the cardiometabolic recommendations are developed with the collaboration of the Cardiology Society and the Diabetes Society or Endocrine Society, and it has been the core of the discussion with the Abu Dhabi government for the implementation of the guidelines and the targets that should be achieved. And we hope that this would be further implemented in every single institution. And it's very important because, as we have seen in our presentation today, there are loads of guidelines and loads of recommendations from cardiologists, from family medicine, from diabetologists, American, European, different American guidelines. And at the end of the day, we need to reflect on our own local patients so that the guidelines would reflect our community and our society. Coming to the second question, the screen negative means that the person does not have an end organ damage, does not have evidence of heart failure or atherosclerosis or CKD or retinopathy. And then consequently, you start looking into the other risk factors, such as their age, their duration of diabetes, and the number of the classic cardiovascular risk factors, such as hypertension, obesity, and diabetes, on top of diabetes. So it's not instead of diabetes. This is in people with diabetes. So if I have diabetes and retinopathy, that would put me as end organ damage at a very high risk category. Now, whether we aim for less than 55 or less than 40, I think it's more or less a bit academic, because the reality, as we have seen from our data in Dubai, the vast majority of our patients are not reaching the target. So let's agree a target, let's try to achieve it and work on why we're not achieving that target. And then we can push further if we feel that we would like to get the target to below 55 or actually to below 40. As you can see from Professor Sabatini's presentation, many of the current guidelines are saying people with diabetes less than 70 or less than 100. We have pushed it to less than 55 in our guidelines, and maybe we need to push it further for some.
Thank you very much, Dr. Hassanin. So the next question is to Professor Sabatin. And again, I'll combine two questions. One of the questions says, what about lipoprotein A? And another question says, why LDL? Why not to combine VLDL and ApoB and high sensitive CRP together to evaluate patients' risk?
Yeah, well, those are great questions, and I'll try to answer them quickly because we're running over and I have to go off to another meeting. So it's a great question. You know, why do we focus on LDL cholesterol? Largely because that's what sort of the way it developed in the laboratories. But it is absolutely true that the remnant cholesterol is also atherogenic. Some folks would say more atherogenic. That's not entirely clear to me that's the case. And so in epidemiologic studies, it certainly is true that non-HDL cholesterol, or better still, ApoB, which is a measure of all the atherogenic lipoproteins, wind up being slightly better predictors. And so even in Vesalius, we had entry criteria for LDL cholesterol, non-HDL, and ApoB. And the guidelines now also give targets for non-HDL cholesterol and ApoB. So the narrow-minded focus on LDL cholesterol is just sort of an artifact of the typical lab reports we get. But I certainly think it's valuable to make sure that there aren't individuals who have high levels of remnant cholesterol or who have lots of particles, but the same amount of cholesterol, but on more particles. That's sort of more shots on goal, to continue the World Cup analogy. And those individuals are at higher risk. So those are absolutely good metrics to look at. In another lipid metric is Lp(a). It's an LDL-like particle attached to which is apolipoprotein a. that is particularly atherogenic, probably pro-inflammatory. It carries a lot of oxidized phospholipid. And in work that we and others have done, probably those particles are about 5 times as atherogenic as a typical LDL particle. The issue is that most people, the levels aren't high, but there's a very long right tail, and some individuals do have very high levels. And so there are several trials being done. We're leading 2 of them, Oceana Outcomes and Pre-Event, looking at a kind of a 4A-like population and a Vesalius-like population of a dedicated Lp(a) reducing drug, olpasiran. There's another one with pelacarsen that should report out this year at AHA. The genetics are very strong for Lp(a) being a risk factor, but we'll need to see the clinical trials. And again, we should get our first sense of the data this year. The PCSK9 inhibitors do lower levels by about 25%. They don't have an indication for Lp(a) lowering. But in a patient whom you were deciding what additional non-statin to add, if they had high levels of Lp(a), at least for now, that's another stone on the teeter-totter, I think, in favor of giving a PCSK9 inhibitor. And the last part to your question was, what about inflammation? Certainly, CRP is a powerful risk factor in multiple different cohorts, looking at both LDL cholesterol and Lp(a) and CRP helps for risk prediction. In terms of therapies, we've talked at extensive length about LDL cholesterol lowering drugs. Lp(a) lowering drugs are right on the horizon. Anti-inflammatory drugs, we did have data in the CANTOS trial for canakinumab that never was sort of developed clinically, but now there's a variety of IL-6 inhibitors being studied. And again, at AHA, the ZEUS trial that Paul Ritger is leading should report out. So soon, maybe even by the end of this year, we'll need to be thinking about measuring and acting on both Lp(a) and inflammation. So hopefully that was helpful, and thanks so much for having me.
Thank you very much, Professor. Now, Dr. Al-Amin, I have a couple of questions. Again, I'll combine them. One question says, is high triglycerides a risk factor for insulin resistance? And the second question, what's the advantage of fenofibrate over statins?
Okay, both are wonderful questions. Actually, the first one is a tough one because the insulin resistance is a very known cause of hypertriglyceridemia. And we've mentioned that in the cartoon illustration of the physiology and pathophysiology of hypertriglyceridemia. It's one of the endogenous factors that boost the production of VLDL carrying triglycerides. So it's very clear that insulin resistance increases the production of triglycerides and the outcomes of that. However, it can also be other way around, where it's a sort of vicious cycle where we have more abundance of hypertriglycerides. This will be degraded because of the more lipolysis than what it should be, more abundance of free fatty acids. And free fatty acids is also a precursor for triglyceride production. But this is a very long pathway to consider as an important factor of hypertriglyceridemia. But physiologically, it can be also taken this way. But the more strong understanding is the insulin resistance is an eminent cause of hypertriglyceridemia, and it can be vice versa. And the second part of the question was fenofibrate over statin. There is no edge of fenofibrate over statin. As we mentioned in our discussion earlier, that most of anti-hypertriglyceridemic agents are on top of a foundation of statin therapy, even in high-risk patients. Even in patients with no atherosclerotic cardiovascular disease, but still having hypertriglyceridemia, statin should be the foundation, and then we build on top of it. Fenofibrates, omega-3, and olezarsen are options for severe hypertriglyceridemia, which is more than 500 milligrams per deciliter, in absence of atherosclerotic cardiovascular disease or risk of having the event. So they are indicated on top of optimum dose of statin therapy and optimum correction of LDL before we go into anti-hyperglycemic, hypertriglyceridemic medications. So there is no edge of fenofibrate on top of a statin, and we cannot just match them together.
Thank you very much, Alamin. Now, I'll take one last question for Professor Giuseppe. One question here says, there is a patient with poorly controlled diabetes and dyslipidemia. The question is, which should we target first? Should we target management of diabetes first, dyslipidemia, or both? Putting in mind that such a patient will be already on polypharmacy. So which one you'll target first?
Okay, in my opinion, both, of course, but we have to remember that cardiovascular death is not only the first cause of death in the world, but especially in diabetic patients. The cause of death in diabetic patients in the vast majority of cases is cardiovascular disease. And then when we treat a diabetic patient, we have in mind that we have to treat the patients, not the diabetes, because the cause of death in this kind of patient is the cardiovascular disease. And the first causes of cardiovascular disease are atherosclerosis, and the first causes of atherosclerosis are cholesterol, LDL cholesterol. And then we know that the patients with diabetes is an high-risk patients if the patients had only another one risk factor, for example, diabetes and hypertension, and stop. And in the vast majority of cases, a very high-risk patients, because the vast majority of patients with diabetes had also atherosclerosis, also subclinical, for example, a plaque on carotid, or a plaque less than 70%, or coronary TAC scan. And then for these patients, the target is 55 milligrams. And then, of course, we have to treat diabetic disease with GLP-1 agonists, for example, or other drugs like agonists of GLP-1 and GIP, for example. But we have to take in mind that it's very important to get the target of LDL, because only with this strategy we can reduce not only MACE, but death.
Thank you very much. Now, before we conclude, one question for any of the speakers to take. It's a question about the statin intolerance. How to manage and how to diagnose.
If we can start, we have really about 3-5% of patients with the real statin intolerance, because they have muscular pain of a bump of CK. But we know also that there are a lot of patients that are unwilling to statin, and we can try with the statin, but in these patients it's impossible to use statin. And then we have almost 10% of patients intolerant or unwilling. We can use bempedoic acid. We can use bempedoic acid in primary prevention, also in secondary prevention, if we are near to the target, because we know that with bempedoic acid we can reduce of 20-25% LDL levels without statin, and then we can combine the bempedoic acid with ezetimibe, or we can use PCSK9 inhibitors, antibodies, or sirna. I usually use antibodies. I usually use evolocumab. If the distance from the target is not near, we can use in my personal practice in these patients. Usually I use bempedoic acid, ezetimibe, and evolocumab.
Thank you very much. With this, we conclude our session today. I'd like to thank all the speakers for wonderful talks. And I'd like to thank as well Amgen for sponsoring this event. And just to remind you, CME will be available 4 weeks after the webinar. And there is an evaluation form that you need to fill and send to your registered. It will be sent to your registered email that you need to fill and send back. Again, a reminder that this webinar is on demand at the EDS Institute website. And I'd like to thank you all again. I'd like to thank all the speakers for this wonderful webinar. Thank you very much and have a good night.
Thank you.
Thank you.
Thank you. Bye.
Thank you.